Ok, allora, buonasera, io sono qua
Good afternoon.
per presentarvi
I
uno
am here
studio
to
che ho
introduce a
condotto
study that was
con
conducted
l'ospedale
by
Bambino
me
Gesù,
with the
che è
Bambino
una
Gesù Hospital, Pediatric Hospital in Rome,
multicentrico
and this
su
is a
45
multi-center
pazienti
study conducted on 45
italiane,
Italian
per le quali
patients,
abbiamo analizzato le caratteristiche
where we did analyze the
neurofisiologiche
electroencephalographic characteristic, the
delle
neurophysiologic
bambine
characteristic of the girls
beneficianti
suffering from
correlato
epilepsy
alla mutazione
correlated to the
PCDH19.
PCDH19
Diciamo, si è
mutation.
già abbondantemente parlato
And we've
delle
been
caratteristiche
talking at length
genetiche
of the
e
genetic
cliniche, per
characteristic,
cui
of
mi
the clinical
soffermo su
characteristics,
le
and I
caratteristiche
would
che già
like
si
to
sa degli aspetti
dwell upon
elettroencefalografici,
what's known about the
sia
EEG
dell'EEG intercritico
findings
che
of the
dell'EEG critico. Nell'EEG
interictal and
intercritico si
ictal
sa che sono
EEG.
presenti delle
We know that
anomalie
as far as the
lente
interictal
laterali che possono
findings, there
essere
are some
sincrone o
slow
asincrone,
lateral
analoghe
anomalies and abnormalities that may be
derivate
synchronous and
alle
asynchronous
anomalie
that
lente, e
are
per quanto riguarda
more
l'EEG
rare with respect to
critico
the
si
slow ones.
tratta
And as far as
dell'enteropilia,
the
della descrizione di crisi
interictal one
focali e di
existing in
crisi
the literature,
generalizzate,
we
le
know
crisi
that we have
focali per
focal
lo più
crises, focal
all'origine dalle
seizures
regioni
tend to originate
frontotemporali.
from the frontal temporal
Lo
regions.
scopo di questo studio
Now, the purpose of this
è stato
study
quello di analizzare
was
i,
the one of analyzing
i tracciati
the
elettroencefalografici di questi
EEG
pazienti al fine di
tracings
trovare degli
of our
elementi
patients
EEG
to find
caratteristici
the
clinici
EEG
che
typical
potessero essere
pattern
utili nel raggiungimento più precoce
that could prove
possibile
useful
della diagnosi. Si
to
tratta di
achieve
uno
a
studio
diagnosis.
retrospettivo nel quale
The
sono
study
stati
is a
inclusi
retrospective study
45 pazienti
when,
provenienti da
and we
13
studied some
diversi
45 patients coming
centri
from
italiani di
45 different
epilepsia, che qui
centers,
sono elencati,
Italian epilepsy
e
centers that are here listed.
sono stati appunto analizzati
And we
335
did
giri, di
analyze some
cui 128
335
direttamente esaminati,
EEG
quindi sono
tracings.
stati è
198
stato
were examined
possibile in
directly,
questi casi visionare direttamente i tracciati,
and
mentre questo anche grazie alle famiglie, alle mamme che hanno potuto
that
hanno
was done thanks to
portato
the
i
mothers and the
tracciati eseguiti
families
anche 30 anni fa,
that
che avevano
submitted the
custodito
tracings that were
dei
done
controlli,
even
e
many
invece
years
in
before.
137, per
And in
137 tracciati non è stato
137
possibile
cases, instead, that was
analizzarli
not possible
direttamente, ma soltanto attraverso
because we
i
could not analyze
controlli.
them directly, but only through the
Sia ai tracciati sia ai report è stata
reports.
applicata una scheda che qui vedete
This is the chart
rappresentata,
that we adopted.
con la quale sono stati raccolti dati
And
riguardanti la
here we
modalità di
collected the data
registrazione,
having to do with
se
the
erano giri
registration
veri o di
modes,
sonno,
whether
l'attività
it was done during
di fondo,
sleep
la
or
presenza di anomalie
while
retiformi
during
o lente,
the awake
la
state.
risposta
And we
alle
also
prove di
registered
attuazione,
the
quindi
response to the
alla
activation
instaurazione di una visione
problems, to the
intermittente
intermittent
all'iperventilazione,
light
e la
stimulation,
presenza o meno di
hyperventilation, the
crisi.
presence or
Qualora
the absence of crisis,
laddove vi erano delle crisi,
and in the
queste
presence
di
of
queste sono
seizures,
state analizzate, sono
we
state
tended to
identificate le
analyze them, and we analyzed all of the different characteristics that were
quindi
typical of the
da seguire come
electroencephalography.
tipo di scarica.
That is a type of discharge.
Quindi di 335 G circa
And
un terzo erano
135 EEGs,
stati registrati con
and a
video,
third of them had a
133
video
con
recording, whilst
terzo con
133
la poligrafia.
came up
La
with a
durata media dei
polygraphic
tracciati
recording.
è risultata essere
The
di 36
tracings
minuti, e
lasted
in
some
14 casi si
36 minutes,
trattava
and in
di
14 cases we had a
intervallati
long-term monitoring
fino a 96 ore
up
di
to
follow-up.
96 hours, that is 4
L'età
days.
media alla quale le pazienti sono state registrate
The average
era
age
stata di 4 anni, quindi con
was of about 4
tracciati
years,
che sono stati eseguiti in pazienti sia di pochi mesi, quindi di 6-8 mesi,
and
sia
the
di
patients
pazienti
were
adulte di
followed
38
for
anni.
some
In media
period, and
sono
the
stati
average age was zero point
analizzati
0.6 up to 38 years of age.
9
We
tracciati
analyzed
per
the 9
paziente,
tracings per
quindi
patient.
un tracciato, in alcuni pazienti un solo tracciato, in altri pazienti anche
In
37
one patient
tracciati.
we had just one
Per
tracing,
alcuni
sometimes in
pazienti
other
abbiamo avuto
patients
la
we had as
possibilità
many as
di
37
studiare
tracings.
tutto il follow-up.
So in some given cases we had the possibility of
Un
studying the
terzo
entire
delle
follow-up of the
pazienti è stato
EEG.
analizzato
One
e
third of the
risultava
patient
risolto, e l'età
saw onset
follow-up
EEG, and
medio
the average
elettroencefalografico è risultato essere di
EEG
2
follow-up
anni,
was equal
quasi
to
3 anni,
almost 3 years.
quindi con un range variabile tra 0, quindi laddove era presente un solo tracciato,
We
e
saw the
37
variability
anni
was
per
equal
i
to 0 up
pazienti
to
per i quali
37,
abbiamo avuto un
depending
follow-up più
uh,
lungo.
on the patient if the patient had been undergoing a longer follow-up period. So we analyzed the basic activity. We analyzed a number of tracings, some of them during the awake phase, others during the somnolence or sleep phase. As to the awake phase, the alpha activity was recognized in a third of the tracings. The theta activity, that is the posterior region activity, was seen in another third, whilst in the remaining third of patients we found global slowing and of the entire activity. And another quota of patients was showing a poor differentiation. And in another group of patients, it was possible to recognize the typical physiological sleep figures that show the good organization of the brain. And the epileptiform abnormalities were seen in some 2/3 of the patients, 64%, meaning that 1/3 of the patients were never presenting at follow-up any abnormalities that were epileptiform abnormalities. So this is something that needs to be considered in the light of what was said this morning as to the broad phenotypical variability. And the epileptiform abnormalities were seen mostly during the sleep stage. So there is a slight prevalence, which is nonetheless marked. Now, as to the characteristics of and the type of abnormalities, we saw that we had typical spikings, spike and wave characteristics, and then we saw some polyspikes in some 6.8%. We can see the presence of abnormalities which were both focal and diffuse. Here, this is a typical case, which is not that much frequent. And here we see a patient aged 11. And here we did observe some spikes and some spike waving trends and tracings. And at the age of 14, we see some diffuse abnormalities that are typical of spike wave tracings that are especially in the frontal areas and bilateral. These abnormalities are very much frequent during the sleep phase. They have been localized in the frontal and bilateral regions. And then later on, at the age of 15, we will find again the presence no longer of diffuse abnormalities, but rather focal abnormalities at the level of the vertex and at the level of the left frontal area. So here, this is a typical aspect of the shape and form of genetic epilepsy. And we know that the abnormalities are usually located in the same side. Now, in the case of genetic epilepsy, this variability may be well understood. And the slow abnormalities are more frequent. And this is something that we've already noticed in the published literature. So we noticed it in some 85% of our patients. And again, the occurrence was more frequent during sleep. And it was especially involving the theta rhythm and the theta waves. Again, the localization was mostly focal. The abnormalities were mostly bilateral, synchronous, and asynchronous. It was mostly frontal temporal or frontotemporal. And this is again very much in line with the epileptiform abnormalities. After intermittent light stimulation and after hypoventilation, very few patients seem to be responding. But we must also say that in the presence of the tracings, we did not have the intermittent light stimulation or the hyperventilation. That was due to the poor collaboration of the patients. And whenever present, we saw the main frequencies of the stimuli. And here again, this is the same patient who in the end was the only one was also displaying the activation of the abnormality whenever she was closing her eyes. As to the ictal EEG, we also noticed some 133 crises, and the recorded crises were reconducible to the average age of 24 years, and especially in patients that were having very few months of age or even that were some 27-year-old. These are the registered and the recorded seizures that were done and recorded during sleep. The duration varies in between 65 seconds and hours. In some 60% of the cases, we had focal crises, focal seizures, and in almost 40% them were diffuse at onset. The origin seems to be a temporal origin, as we've said before, and that is a datum that was confirmed by this study. And some 80% of the cases had a temporal origin. In only one patient, we had a non-convulsive epilepticus status, and the cluster seizures were not considered as a status epilepticus, but rather they were considered individually. So the focal and diffuse seizures. As far as focal seizures, this is the example, and as I said, we found some 60% of cases, and most of them were located in the temporal region, and this is the example. They mostly, the onset is mostly during sleep, and here again, this is one example of a seizure. I won't dwell much upon the semiology, but nonetheless, this is an effective semiology. And there is a clear sign of fear. This is another patient, age 14. She has some focal seizures, temporal origin on the left hemisphere in this case. This is a cluster of seizures. And as I said, the semiology here is a minimum clinical semiology. And had it not been recorded, probably one would not even diagnose the seizures, and the parents would not be aware of them. And this is another cluster, another discharge, paroxysmal discharge, rapid activity affecting the temporal region, left temporal region. And here maybe we can see another counter-lateral region diffusion. Here we see the rapid activity of the waves on the opposite hemisphere, and on the left hemisphere we still highlight some paroxysmal activity at the level of frontotemporal regions. And here we will see this again with other examples. By means of this example, we would like to underline the temporal origin and the rotation of the crisis affecting the right and left hemispheres. And by saying this, I would like to stress that these crises only too often are subclinical in nature, and prolonged monitoring could prove useful in diagnosing them. This is another patient with another interictal or ictal activity which is rapid, localized in the frontal right hemisphere. In this case, the activity was prolonged and it lasted for a couple of hours, and it was possible to interrupt it only while administering diazepam. We analyzed the origin of the seizures, so the location, and we said that it was mostly temporal, but then we also went on analyzing the evolution of the ictal discharge, so the synchronous activity at both hemisphere level, and in some 20% of the crises we did observe some asynchronous seizures affecting the right and left hemispheres. So here we have the clear example of a seizure starting in the temporal region of the left hemisphere, then it is diffused to the temporal region of the opposite hemisphere, the right hemisphere, and in the course of the seizure affecting bilaterally the temporal regions, it seems that the discharge frequency affecting both regions seems to be totally independent. We observe some synchronies, and as we can very well see, we end up with an independent discharge of seizures on both hemispheres, first on the left-hand side and then afterwards on the right-hand side. This is another cluster of seizures, the same patient, and here we see how the types of discharges and the frequency of discharges affecting the temporal regions is totally asynchronous, as if the crisis were and the seizures were independent. Here again we see that they start on the right-hand side, they pass on the left-hand side, then they are being diffused on both the temporal regions, then they end up first on the right-hand side and then afterwards on the left-hand side, as if they were independent. Here this is another patient. Here we see another cluster of seizures originating in the right temporal region, then it diffuses on the left region, and then here we see the ending of the crisis first on the left hand side and then on the right hand side, as if there is a totally independent pattern. Now these are the characteristics for the focal crisis. As far as the diffuse onset seizures, we see that they tend to start with a diffuse pattern, and they are abruptly ending on both hemispheres. This is accounting for some 40% of the seizures. Only too often they start off with a spike potential, which is diffuse and widespread, and little by little it is reduced in its frequency. And these seizures are sometimes generalized, so much so that we can find some focal elements. And in this case, we may have a hypertone as opposed to the left-hand side. Then later on, we see that the seizure seems to be asymmetrically progressing on both hemispheres. Here we see an apnea, which has been recorded, which brings about a desaturation. And here we see that this seizure is affecting synchronously both hemispheres, and then it is abruptly ending and affecting both hemispheres. This is another patient. The voltage, as we can see, is and the amplitude is very low. It starts off with some spikes. The rapid activity then is growing in frequencies. It is diffused on both hemispheres. It has been spread at both hemispheres, and then it ends abruptly.
Another diffuse onset seizure. I'm going to move very rapidly. This is another seizure. Here again we see a greater hypertone on one side compared to the other. That's why we call them diffuse onset rather than generalized seizures. And the end is equally diffuse. I don't want to dwell on the clinical aspects because that's going to be taken up by the next presentation, but these diffuse seizures may be of two types, essentially, of an atonic vibration type or characterized, as was the case in the first slide I showed you, characterized by hypotonia, apnea, and desaturation. In conclusion, this study, thanks to the cooperation of the families and facilities that referred the patients and the recordings to us, made it possible to better define EEG features of this form of epilepsy, both interictal and ictal. Epileptiform abnormalities were found in 2/3 of patients, and 1/3 patients never showed epileptiform abnormalities in the course of a many-year follow-up. And there's great variability between patients and even within the same patient during the follow-up. There can be phases that are very rich in abnormalities and quiescent phases in which there are no abnormalities at all. As to the seizures, therefore, there is a distinction between focal and diffuse seizures. The focal are temporal in origin, but once again, we have great variability when it comes to the site of onset. Thank you for your kind attention. I just want to stress that she was concise, and so she didn't raise the problem of differential diagnosis, but the seizures, which had the asynchronous involvement of the two hemispheres, in the Dravet syndrome you will never see. I mean, that is a model on its own. There are similitudes with age-dependent forms on the one hand, and on the other with migrating type progressions. And even the seizures that have been described as diffuse might be misleading. They could mimic a convulsion, whereas the motor component is often reactive with a few abrupt movements, but they are not generalized tonic-clonic seizures. In order to be able to break things down into phenotypes, either you go this way, or you have convulsions, and therefore there are no difference between patients. I just wanted to make a comment on these diffuse seizures. I hadn't seen the data yet. Nevertheless, I don't know if we should call them diffuse seizures. Maybe I don't quite understand what you mean, but actually those seizures have a focal onset with rapid activity in the frontal region on the left and on the right. So if I were to look at this, I would have said, oh, well, I think these are frontal seizures that come from the deeper mesial regions that become generalized with an immediate diffusion through the corpus callosum. It's different from those forms that take a long time to become diffuse. The frontal seizures diffuse very, very rapidly in the corpus callosum and elsewhere, so this ought to be discussed. Another point I don't quite understand is could there be an interference in the interictal EEG findings due to the pharmacological treatment? Well, we had some difficulty in defining that type of seizure, although in literature these are defined as generalized, but we don't think that the term generalized is very suited for this case. They could be focal cases or seizures, but it's often difficult to find the origin. I guess we could talk about it. But therapy, we haven't analyzed it. Not so far. We have not assessed the type of treatment patients are undergoing at the time of the recordings. Yes, but you were very good because the term diffuse seizure is one that ought to be used not from a clinical point of view, but from an EEG point of view. There is no diffuse clinical seizure. So you raised the right objection. But I think that she tried to prevent that because she actually used the term diffuse. There are falsely generalized patterns. The pattern at first glance is that of a bilateral expression or manifestation. Then The way it becomes bilateral is difficult to assess based only on that EEG reading.